Good afternoon, all. Oh, good morning. I'm sorry. Jesus. Uh, oh boy, it's been intense. We'd like to begin our second session this morning on responding to work-related health hazards of the informal sector, Part 1. And our moderator is Dr. John Howard, who's the director of the CDC, National Institute of Occupational and Health Safety, whom I actually have worked with and for. And I'm very, very pleased, sir, that you accepted our invitation. And we look forward to your taking us through this. Thank you.
Thanks, Clarion, and welcome to Washington, everybody. I'm happy to moderate this session. We have some wonderful speakers from all over the world. In the U.S., we often don't talk about the topic of our panel, which is responding to the work-related health needs of the informal sector as an informal sector. It's not really a word that we use at NIOSH that much, but certainly if you translate it to low-wage jobs, they represent nearly half of all new jobs that are created in the United States. So we certainly have this as an issue. At the same time, evidence from research shows that those same people are at an increased risk of work-related injuries and illnesses, and certainly that can affect them, their family, the enterprise that they are a part of, and the nation's economic health. In the U.S., as has already been alluded to, there are some good channels in the health program that is federally funded. The federally qualified health centers, which is funded by the Health Resources and Services Administration, or HRSA, which is part of my department, the Department of Health and Human Services. They sponsor community and migrant health centers that provide services to individuals who are frequently employed in this so-called informal health sector in the United States. And the Affordable Care Act, the Patient Protection and Affordable Care Act, which was passed in 2010, provides a special fund over the first 5 years to support expansion of these clinical centers and their services to increase the number of patients served by this population, which estimates number about 10 million individuals. How these centers do that, of course, is the big question. And we in the National Institute are trying to assist these centers in meeting that task by helping them provide preventive health services. But in the crush of providing rescue medicine, it is often very difficult to sandwich in preventive occupational health services, even though the topic is widely accepted in those clinics. So we're working very hard to do that. We're interfacing in several different areas to improve diagnosis, management, and patient education of occupational health in those centers. So with that brief introduction to what the United States is doing, I'm very happy to introduce our panel today. Our first speaker is Ivanov, who is a team lead at Workers' Health World Health Organization and is also on the workshop planning committee for this event. So, Ivan.
Thank you, John. Well, good morning, everybody.
Good morning. Good morning.
Well, the U.S. always provides an inspiration. We often hear from developing countries, why should we do something if they haven't done it in the U.S.? So with this, I would like to talk to you about the movement that is initiated by WHO and other partners to enhance the abilities of primary care to deal with work-related health needs. And because primary care is currently the only most available option for informal sector workers, they are those who benefit from these enhanced capacities. Of course, the formal sector workers, those who have specialized occupational health services, are those that benefit most of the specialization of occupational health, but we're trying to make sure that all workers in the world are taken care for their work-related health needs, because the lack of such care causes about 4% of GDP annual losses worldwide. And this is enormous, enormous loss. Now, I'll talk about why we talk specifically about universal health coverage for workers, why workers as part of universal health coverage, why not everybody. And what is the coverage in occupational health? What are the primary care-based interventions for informal sector workers? And what are the challenges and the way forward? Yesterday, I argued that the universal health coverage is for everybody. It's not for specific populations, but also that specific populations have specific health needs. And universal health coverage responding to the covering the needed health services also need to be sensitive to the specific health needs that the different populations may have. And in 2007, the World Health Assembly adopted a global plan of action on workers' health, which sets the 10-year agenda of the health sector worldwide to respond to the specific health needs of workers. And as part of that resolution of the Assembly, the member states of WHO committed to work towards full coverage of our workers, including those in the informal economy, small, medium-sized enterprises, agriculture, migrant and contractual workers, with essential interventions and basic health services for primary prevention of occupational and work-related diseases and injuries. In addition to that, the post-2015 agenda that is already emerging and reflected in the outcome document of the open-ended working group that is on your desk includes some targets that are close also to this vision of coverage of workers with occupational health and with interventions to address their specific health needs. The universal health coverage target in the proposed goal 3 to ensure healthy lives and promoting well-being of all ages. Specifically also the target on substantially reducing the number of deaths and illnesses from hazardous chemicals in air, water, soil pollution and contamination. And many of these diseases are directly caused by the work-related or occupational exposures. But also the goal on promoting sustained, inclusive, and sustainable economic growth, full and productive employment, and decent work for all, contains a target to protect labor rights and promote safe and secure working environments. I would argue here that it's not only safe, but also healthy working environments, because the right is to safe and healthy, not only to safe. For all workers, including migrant workers, particularly women migrants, and those in precarious employment, which is the word for informal sector in the Sustainable Development Goals. But also, occupational health is a human right of everyone, not only for those workers with labor contracts. Occupational health and just and favorable working conditions is reflected in the Universal Declaration on Human Rights and also the International Covenant on Economic, Social, and Human Rights talks specifically about improving of all aspects of environment and industrial hygiene and the prevention, treatment, and control of epidemic, endemic, occupational, and other diseases. So it will be good to align also the Sustainable Development Goals with these covenants and including occupational diseases as part of the Sustainable Development Goals. A third argument for dealing with workers' health as part of universal health coverage is that occupational risks per se have also important health impact. They are among the 10 leading causes of leading risks for disease and disability worldwide. There is concern that still too many workers do not have coverage of the conventional occupational health services, which are models that provide specialized occupational health services, risk assessment, prevention, and health surveillance to workers in organized enterprises and usually in big enterprises. So workers in the micro, small, medium enterprises together with informal sector workers are also deprived of accessing these services. But also the coverage of employment injury benefits is very unequal and is very low. It's average. The average for the world is only about 30% of the workforce is covered with such injury schemes, and they can be both compulsory and they can be voluntary. And I was very interested to hear this morning the discussion about extending such coverage through the supply networks. That would be something that is really very, very needed. Now, when we talk about coverage in occupational health, how do we measure coverage in occupational health? This cube, the famous cube, that is not my cube, Barry, so that is the cube of the World Health Organization. This is the adaptation of the cube to the world of work. And the dimensions of coverage, on one hand, reducing the cost sharing. In occupational health, the cost sharing has very important implications. Like in the environmental area, the principle is polluters pays, the polluter pays principle. The same is in occupational health. Because someone makes profit out of economic activity, those who make profit should bear all the consequences of exposing workers and harming their health. The society at large should not be bearing these economic consequences. This is externalization of costs. And that people who happen to get sick because of work, they should have social protection, like my colleague Barry argued, independently of whether they have a formal contract or informal contract. So this is a very important aspect to discuss when we move toward universal health coverage. The interventions that are provided also to workers, whether they are provided only with curative interventions or they're provided also with interventions for primary prevention of occupational diseases or for promotion, and who is covered. In this case, we're talking today about informal sector workers. Very close to this are the micro enterprises, small enterprises, farmers, migrants. All of these are disadvantaged groups in terms of coverage. Working poor and the informal sector are the target population for WHO for scaling up coverage. We're talking about 1 billion workers below the poverty line of $2 per day. The informal sector is up to 50% of the labor force, and in some countries, like we heard about India, is almost 90% of the labor force. And the workers' health is directly linked to income earning potential. Informal sector workers sometimes are the only breadwinner of the family. And if the worker gets sick or injured because of his or her work, the whole family falls into persistent poverty. So our activity in protecting the health of informal sector workers and extending to them health services to prevent these diseases and injuries arising from their work is part of our activities to lift up people from poverty. When we measure coverage of occupational health services, sometimes we talk about occupational health services in terms of facility or a department. This is how we measure this 15% coverage. Worldwide, people have access to this type of facilities and departments of occupational health, or we can measure coverage of the individual interventions for occupational health. For example, how many people are covered with risk assessments at workplaces, how many people have access to management of occupational diseases or medical surveillance. And certainly, the third dimension is we can talk about financial coverage. This is the proportion of occupational health care costs to the individual that are covered by public funds through pooling, insurance, and budget. And as I argued, because occupational health is an externality of the production process, this coverage should be 100%. The primary care-based interventions for informal sector workforce is something that WHO has worked with countries to identify and to popularize and scale up, that we are working currently to scale up. These interventions In 2011, we had a meeting for the first time actually in history between occupational health providers and primary healthcare providers, general practitioners, to discuss the connections between health and labor at this level of primary care level of the health system. The discussion was not easy, but that meeting came up to recommending 3 groups of interventions that can be and should be provided at the primary care level of the health system. The advice for workplace improvements, the control of work-related and occupational diseases and injuries, and the promotion of fitness for work. We looked also in the literature whether there is evidence that such type of interventions are delivered or what is being delivered at the primary care level of health systems regarding the health of workers. And we found that a group of environmental interventions and behavioral interventions for primary prevention of occupational and work-related diseases and injuries are delivered in countries where primary care has responsibility for a defined area of the turf, a defined catchment area, together with its population. It's not in primary care systems that are based on liberal medicine and free choice of provider. So you can see in Brazil, China, Indonesia, Iran, Tanzania, Thailand, these interventions are being delivered. The second group of interventions that is delivered in many, many countries across from continents and types of primary care and health systems are the interventions for case management of occupational and work-related diseases, including taking work history, reporting occupational diseases, follow-up of cases, medical surveillance. So we found in both developing countries and in developed European countries in North America evidence for delivery of these interventions. Where we went further and went to the countries and interviewed primary care providers in 6 countries to find out what actually they're doing about the health of workers. And we did these studies with support of our collaborating centers for occupational health that we have in many countries and partners. And we picked 1 country per region based on feasibility and where we had networks. So we studied in Colombia, in Italy, in Iran, in Philippines, Thailand, and South Africa. And regarding these are the results, whether the interventions are delivered or not, in terms of primary prevention at the workplace. In most countries, except in Italy, where the doctors do not have any rights to enter workplaces, there is some delivery of workplace visits and surveys, and also to a certain extent, education of workers, health education of workers about how they can work in a safer and healthier way. The second group of interventions regarding the detection and management of occupational and work-related diseases have been delivered in all countries that we studied to different extent and by also different providers. In Italy, for example, general practitioners are involved, while in other countries, in Thailand, in South Africa, these are either nurses or public health officers that are involved in these interventions. But they include taking work history, clinical examination, notification of suspected cases of occupational and work-related diseases, because at the primary care level, there is usually not yet a defined diagnosis. It's more of a symptom, so a health problem that is being notified to the public health authorities, and then measures are taken in the case of a cluster for prevention of further complications. The contacts and visits to patient workplace, provision of medicines for treatment in some countries, and personal protective equipment in Thailand. The third group of interventions is the fitness for work and health surveillance that includes some preventive medical examinations. We heard about the screenings of farmers for pesticides in Thailand, other interventions in, for example, in the Philippines with commercial sex workers. I have to measure my mouth because in some countries that word is not appropriate. but these interventions are provided, including return to work counseling and screening of high-risk groups. We used the international One Health costing tool, which is a tool for costing health interventions developed by WHO, World Bank, International Health Partnerships, and other partners to estimate how much these interventions do cost when they are delivered at the primary care level in the different countries. And you can see here the results in US dollars, but they are calculated in purchasing power parity, so you can compare the results across the countries. The highest number, the highest amount of dollars actually is being spent in Iran, and it is not a surprise because Iran has a very well-developed primary care system with a very strong emphasis on occupational health, and they're providing visits to workplaces once or twice a year through the primary care system to all workplaces. So this is the reason of the high cost. And South Africa is an emerging player in providing health interventions at a very starting level, but they have capacities to scale up further. The barriers for delivery of these interventions that we mentioned, that we identified through the systematic reviews, is the difficulties to reach out to workplaces in the informal sector. This is basically a service, it's not an inspection. So if you are invited to provide advice and support, then they would do. So that is also related to the ability of the informal sector workplaces and informal sector workers to uptake such interventions and to seek help from primary health care. The shortage of health workforce, the lack of occupational health training for primary care providers in several countries. Occupational health is not part of the undergraduate studies in medicine, in nursing, so they have difficulties when they face work-related health problems to address these problems. Sometimes no time even to visit workplaces. The good example in several countries where they use a lot of community health workers and health volunteers is that if the doctors and nurses do not have the time to visit workplaces, or might be very expensive to send doctors and nurses to workplaces, they use some simple checklist, and with trained community health workers, they can collect data and intervene back on the workplace. The second group of barriers for delivery include the case management of occupational diseases and injuries, particularly the lack of knowledge of occupational diseases, their causes, very difficult diagnostic and exposure criteria, difficulties with employers, sometimes fear for repression that if the doctor, the nurse, or the public health officer report the occupational disease, there might be problems with the employer, waiting time for specialists, and basically the lack of connection between primary care and the specialists in occupational medicine and occupational health care. For example, in Namibia, where we intervened at the request of the Ministry of Health to strengthen the national policy for occupational health, we found that actually Namibia has only 7 or 8 specialists in occupational health, and all of them working for big mining companies. So the people, the population, workers and farmers outside of mining companies had no access to there's no referral pathway. So there were discussions between the Ministry of Health and the mining companies to eventually open the specialists of these mining companies so they can have some time to see outside patients who are not workers of the mines. Now, the challenges on the way forward, we were encouraged by these studies. We saw that it is possible to deliver certain interventions for improving the health of workers, keeping them on the job through primary care. Now, what we can do to further scale this up. The directions of WHO is to enable the primary care to address workers' health by working with ministries of health so they can include work-related tasks and activities in the terms of reference of the primary care providers, that they can establish referral pathways to occupational health services. They can set up programs for training and retraining of primary care providers, ideally as part of the continuous medical education. And also strengthen occupational health services, the specialized occupational health services where they exist, increase their numbers, but also improve the quality and the effectiveness of delivery, and ensure that they are connected to primary care. And of course, working with ministries of health and the countries to provide financial protection for all workers, including workers in the informal sector, through social health insurance and combination between social health insurance and non-contributory coverage for the poor, and scaling up coverage of employment injury benefits. Dealing with informal work needs to be done as informal work has to be considered as a social determinant of health. And in general, this is the recommendation of the WHO Commission on Social Determinants, that employment is an important social determinant of health. So if we deal with informal work as a social determinant, we can achieve better understanding and to remove the barriers of access to health services, which are not always financial based, but there are some structural, there are some cultural barriers that we have to identify, systematically remove, including the health-seeking behavior we have to understand better, including the loss of income, the lack of social protection, and how health systems actually can address these barriers. What is the impact of formalization, which is not always very positive in terms of health. In some cases, there is evidence that the formalization can lead actually to negative health impact. And of course, the challenge of intersectoral collaboration between decent work, full and productive employment, social protection, poverty reduction, and urban development. The health sector can do a number of things to address informal work, as considering work as an environmental determinant in addition of being a social determinant, by mapping health risk, occupational, environmental, behavior health risk in typical informal settings, like has been done in India with very stimulating results, identifying the cost-effective interventions for health protection and promotion. At this level where the resources are short, it is important to have interventions that prevent as much as possible disability-adjusted life years for the cost of reasonable cost, less than the cost of one per capita GDP per year. The options for delivery channels for informal sector workers, using clinical outreach, community-based primary care, and also engaging non-health actors that can be particularly useful about primary prevention at the workplace. And third is extending financial health protection to informal workforce through strategies and policy options for financial coverage, including the combination between contributory and non-contributory schemes, and differentiating between poor and non-poor informal workers, social protection, employment injury benefits, and considering ultimately workers and vulnerable employment as part of the universal health coverage. WHO is currently finalizing a set of essential interventions that I mentioned, and they're being included in the international One Health costing tool, so countries can integrate these interventions in their health accounts and in their budgets. There is also methodology for measuring workers' health coverage that is being finalized, modules for training of primary care providers for different settings that countries can use to enhance their capacities, tools for delivery of interventions in low-resource settings, support for countries to develop national roadmaps for scaling up workers' health coverage, and of course, our special attention of dealing with informal sector workforce from the point of view of social determinants, occupational health, and health financing. Thank you very much.